right to give you MD degree right now, I would. Dr. Mikovits is one of the most knowledgeable people, probably in not only in California, United States, in TMJ problems and severe cases where nobody can help. He will do restorative and orthodontic treatment, and this is one of the cases that we treated together. It's an interesting problem, and I'm sure Amy, she didn't see any of this, so it will be probably interesting for her to see that too. It comes to the one thing is what can you do with the facial skeleton to make a stable result? Because we can do any surgery and we can do a lot of different things, but is it going to be stable? And the stability depends on many, many factors, which we're going to talk about during this discussion. And one of them is TMJ. And I'm not going to repeat what Dr. Mikovits talked extensively about. Again, he is very, very knowledgeable on this subject, and he talked about different protocols that Amy went through in preparation for this procedure, and it's a literally team approach. Like, you have to take it as a team. There's a orthodontist, there's a TMJ doctor, there's a rheumatologist, MD, and there is a surgeon who will do the operation, and then the post-op management includes all those specialists. So initially, the diagnosis is important. You know, when the people come to me, it's already they've been diagnosed, so it's easy for me. But if they were not, then you have to pick it up, and it's symptomatic diagnosis most of the time. It lines up with the estrogen production on the female patient, and you just really have to catch it up early if you can. So we'll talk orthodontic and surgical treatment planning on a 2D planning, 3D planning, facial analysis, facial planning, and what we can do with the face with no joints. And our goal is to do the not only operation but stable result that will last. So the first thing is, obviously, we take pictures, 2D photography. You know, I have a 3D camera, and we've been trying to use it. It just it's a cool thing to have, but it doesn't give us any more information than the regular 2D photos. The only thing that it has a value, of course, is a 3D scan. So first we do frontal view pictures, some open mouth pictures so we can see the jaws, and let's see, let me go to the PowerPoint mode. Okay. So what do we do? I treat those faces as I'm not a dentist at all. Like, I have no teeth in the mouth. I would treat this face as the patient would come to a plastic surgeon and he has no knowledge about occlusion, and he just wants to put the anatomic marks, so the pogonion, nasion, cheekbones, subnasally, and of course the exposition of the upper tooth in a space, length of the jaw desired, and then the main question is how far you can advance the mandible, how far you can impact the maxilla, and what can actually be done. So with cases like this, when we have complete or partial joint destruction, arthritis, osteoarthritis, in this case, the diagnosis was the juvenile osteoarthritis because it happened in the early years, and all the orthodontic preparation is designed to put the occlusion together with the, in this case, with a 3-piece upper jaw osteotomy. So we do need to have some spaces in between the teeth to do osteotomies. And the lower jaw is a single bilateral sagittal split osteotomy. So again, tomograms, we prepare the joints medically with different medications like simvastatin, tetracycline, vitamins, and rheumatology medications. Dr. Mikovits extensively talked on that. And then we do our tomograms. Not only aesthetic importance of the face, but also the airway. We have a straw-like airway, very small. We can physically measure the transverse dimension on each nasal, glottic, and pharyngeal airway, and record that. So the diagnosis is we have a medical diagnosis of the team J joint, which is osteoarthritis. We have remainance of the joints that are stable, and we medicate them. We have class 2 dysgnathia. We have class 2 molar, class 2 premolar, and canine. And our goal is to treat this, and how can we get the maximum result? And measuring this overjet is approximately 10 millimeters. If we just do the lower jaw and advance the lower jaw to close the bite and to get the closure of this gap, would that be sufficient to do the case? And that all comes in mind when we plan it. We ask the patient to do weird things like advancing the lower jaw forward as much as they can, to see how the soft tissue profile will stretch, if we would need additional genioplasty to get more advanced result. We'll look at the lip and lip competence. And of course, we'll look at the different views, symmetries of the facial skeleton. So the next step would be to do the cephalometric analysis. And again, the conventional cephalometric analysis is coming out of favor completely. We don't look at the numbers. We only look at the positional numbers, the true vertical plane, the position and the X position of the upper incisor is number one key to the facial planning. And in those cases, the number one thing we need to do to get a stable result is to get the protective occlusion. If we go back on the cases on the slides here, we can see how this occlusal plane is so steep. It's probably like 26 degrees, which is extremely steep. If we put the head in the natural head position, the natural head position is important because we can reproduce the head position all over again, not only on the photographs, but also in the CT scan. And all the records, we want to take consistent pictures in the natural head position, consistent tomograms in the natural head positions, because later we're going to be merging them on the 2D and 3D images. You can see there are some facial markers there. We call them indelible markers, fiducial markers on the face, and that's how we orient the 3D volume. I think in my practice, the 2D planning is 95–98% accurate to the final result on the class 2 patient. And it happens to be that when we lengthen the jaw, we can predict pretty well the soft tissue thickness and more or less basic profile, anatomy and outline. So let's see here. This is important numbers on the planning. Our Pogonian, which is this point here, comes forward an inch, 24 millimeters. Our overjet, we already know that it's about 10. So how do we get that projection of the chin that is an inch or more? And it is done by making occlusal plane flat surgically. So we have to take upper and lower jaw and plan, build in into surgery the rotation of the whole facial skeleton. In this case, it's approximately 16 to 17 degrees. So we take the whole facial skeleton and rotate it 16 degrees. Recently, we've been doing 3D diagnosis for those patients, and recently I'm talking about 10 years, maybe more. And this is the 3D planning. So after 2D, and we have the basic numbers in place on how to get the how to position the jaws. Now we need to go and plan everything in 3D. So 3D planning. Again, this is the 3D volume. So that's what I get from that scan. And we position that into the software that helps us to plan the whole surgery. So the whole surgery is planned before the surgery. So when we go for the actual case, we have few plastic splints, and that's all we have. So we plan for 3 pieces of work. There's a sagittal split osteotomies that are done. We're fixing the facial asymmetry by correcting a yaw and doing aggressive counterclockwise rotation of the facial skeleton. That will not only help the aesthetic profile, but also will help the airway. So our plan is to triple the airway volume with this surgery. So now when we have the occlusion together, now this is the main trick right there, is to get the occlusal plane advancement. So this is another trick. How do you maximize your sagittal split? How do you want this chin out an inch? So another trick is to move the upper incisor forward. On the face, like M is, it's very hard to move incisor forward more than we did. So we plan for about 4 millimeters. Otherwise, it will be just too protrusive. But 4 millimeters plus 10, it's already 14, and then the rest would be the occlusal plane rotation. And that's what happens with occlusal plane. Here, we're gonna make it flat, right there, right there. So this is we make it 4 degrees, but in actuality, I think we did almost 0 at the end because we were controlling impaction during the surgery. So now we want to make sure the jaw is symmetric during the operation. Of course, there's a lot of bone volume difference on the left and right side. The left side has a worse condyle, and you can see the horseshoe, the upper jaw, and that's what takes the planning. So I'm going to skip through this planning and obviously compare the left and right side. Then the genioplasty plan. So chin about 4 millimeters. You don't want to do chin more than 4 millimeters because some patients have anesthetic step to it, and then the splint production. So this is very important. This is the key of the surgery. During those operations, and I have some colleagues that do upper jaw first in big asymmetry cases. I still do the lower jaw first, always, because I find this to be more accurate. But in this case, this is the key. This area is the splint area, and we'll see on the slides later the exact thing I'm talking about. But this is the next thing. We're going to go to this slide. So this is preoperative scan. This is the lower jaw position, the new lower jaw position. This is how it's done. The lower jaw gets done first during the surgery. That's the first step. And then we fixate this in this new position. Then we separate the upper jaw and put the upper jaw, stack it on top of the lower, and get the final face. And then we do the chin. So lower jaw gets done first. Anatomical difference, we can see advancement is pretty large, 19 millimeters gap, so we need an extra large plate. We can see this antigonial notch is very advanced, so we'll be putting some bone graft there. This antigonial notch is much better looking notch with less deformity. And these are the 3D numbers now. So we looked at the 2D numbers. This is 3D. It doesn't count the chin. So 22 plus 4, approximately 26 millimeters at the chin advancement. Upper incisor comes forward approximately 4, and the midline of the lower incisor 10. So that controls the overjet. So the rest, inch and a half, comes from this rotation, which is counterclockwise rotation. Again, planning takes place. You plan it as a plastic surgeon. You know, the only thing dental here is midlines, nothing else. And you do certain things like asymmetry correction, and again, numbers. I find all these numbers irrelevant. I put them, you know, for the people, you know, it doesn't make any sense at all. So the conventional ortho you know, SNA, SNB, you know, absolutely no sense because everybody is different, and treatment to the cranial base, it's completely outdated. So again, 2D planning, going into surgery. This is our post-op panel with the condyles nicely in place, plates, chin, and big gaps osteotomies. You can see how this is a much better side than this, and much smaller condyle on this side. This is the surgery here in the frontal view, symmetry, advancement. So we can see how occlusal plane, and so all those records are taken in the natural head position. So when we show them, they're all in the natural head position, and this is a very flat occlusal plane. You can see the airway anatomy now. So it probably tripled, quadrupled in the numbers if we look at particular numbers. Condyles, so we continue on those medications. I think except for Embrel, we continue on most of the medications during the surgery and after. And then we look for the fusion. So our goal is for those gaps to fuse and those condyles to be stable. If those condyles are traumatized during operation, too much pressure, or after surgery, too much pressure, we are in trouble because we will have relapse. And not Amy, not me, not anybody want to have a relapse. A lot of doctors in the United States will not do this. So they'll say this is not doable. It's impossible to do. What's possible is to do artificial joints, is to take that joint out and put titanium and then do orthognathic surgery, because they don't believe that this joint will be stable. They believe in relapse. It's true if you don't do 7 things. So one of them is making occlusal plane completely flat. You see how flat we made it? 90 degrees. You can make it negative. If you make it negative, then you get the molars hanging down, a little bit less aesthetic smile. But 90 degrees, nobody complained. I do a lot of 90 degrees occlusal planes for patients like this. Then the second trick, obviously, is the medication to the joint. So flat occlusal plane, the medicated joint. The splint therapy before the surgery is the third one. The fourth one would be double plating and screws, bicortical screws. Some people don't believe in bicortical screws. It's a great tool. Obviously, don't put them first. Put the plates first. Stabilize the condyle position, then do bicortical screws for transverse stability. Bone grafting. Do lots of bone grafting. Your own bone, or I mean, obviously, patient's bone, or allografts. You can do that. That helps with the fusion. So that's already 5. And then the most important, I think, in this case will be skeletal fixation. You have to release pressure from the joint. And how do you do that? You have to do elastics. You can do elastics on braces to move the teeth. There's a problem with that, because if you do long-term elastics on the teeth, you move the teeth, extrude the teeth with a three-piece segmental Lefort osteotomy like here. It can be a problem too. So you do skeletal fixation. So you can see those screws right there. Here. These are the screws to help to do skeletal fixation. They call TEDs, temporary anchorage devices. So we put them in between the roots for the bone. Patients, some patients like them, some patients don't like them, but they understand the benefit. A lot of elastics go on those screws. And then we do long-term elastics. So it's not just 1 month or 2 months. It's 6 months or sometimes years. I have a patient that even worse condyle than Amy, and then we are, I think, 2nd year in elastics. Braces are off, we just have the screws, and we just keep it. Because we have a very small overbite after all, and we want to keep that very stable. So we can see the skeletal change, so we'll scan through. This is our pre-op planning, and this is a post-op result. And it's very accurate, in my opinion. Of course, there's some deviance to that, but it's this is the picture. Faces always look better. This is 5 weeks after surgery, so we're still swollen. Lots of elastics. Profile. 16 months after surgery. Okay, so big advancement, and we can see on the day of. So braces were off, and we're still keeping those screws in here. And this is pre-op occlusion, and we just took the screws off after braces. So you can keep those elastics on for those patients. It does protect the joint, so that's your number 7 key to a stable result like this. Deformity, transverse, vertical, horizontal, sagittal corrected. Again, big difference in the profile, and obviously there's a lot of things that go into this, and Amy has been one of the best patients with the compliance and all the appointments and everything. She was doing a good job as a patient after surgery, and we look for the healing. And there is some months you have to wait. So a lot of people ask a question: when can I play basketball, karate, do the sports? So we say 9 months. Why 9 months? Because it takes time for the bone to heal, and you can see all those gaps they fill in with the bone. Even if you put the bone graft in there, it's initially very transparent, like it's not there at all. But then it calcifies and it brings the fuses the segments together. And this is our beautiful Amy. So I really wanted to thank you, Amy, for letting us present the case, for letting us present her case not only here but in Europe. I was presenting you a couple of weeks ago, and it was a lot of questions were asked and about the protocol for the joints and everything. So it's a real thing, and those patients don't have to be left with the faces like preoperative. And there are a lot of them that just need to be diagnosed, treated, and they don't need total joints. If you follow the protocol, we can take the risk and do this without doing humongous scars, putting prosthetic joints, because there's a longevity in those joints, and how long they're going to last, complications, scars. We don't want to put a scar on a 23-year-old beautiful face, so it's better to avoid it as much as we can. But again, it's a team approach. I really want to thank you, Dr. Mikowitz, for preparing this case orthodontically and Team J-wise, and our retention is important. So there's about a year of orthodontics after fine-tuning the bite and everything. So again, he is much more knowledgeable than anybody in terms of Team J. So ask him questions. I send all my complicated